In this podcast, we're going to discuss shortness of breath, specifically when you should be thinking, is this a pulmonary embolism? Let's start with a case. Jenny is a 29-year-old female who tells you she's visiting from Australia. She just got in last night. She tells you that this morning, while she was out walking, she had onset of shortness of breath and chest pain. When reviewing her history of present illness, she tells you that the shortness of breath is worse with exertion, and she ranks the pain an 8 out of 10. Nothing makes it better. Next, you'll do a quick review of systems, focusing particularly on those pertinent to shortness of breath. Remember to ask about chest pain, cough, sputum production, hemoptysis, fevers, nausea, dizziness, and weakness. You'll want to ask about her past medical history, specifically if she has any history of pulmonary disease, like asthma, COPD, if she's ever had a pulmonary embolism or deep venous thrombosis, as well as her past surgical history, and lastly, ask about medications. Jenny is taking oral contraceptives. Next, look at your vitals. Abnormal vitals should make you more concerned. And your physical exam. Particularly focus on cardiovascular, pulmonary, abdominal, and general. At this point, you should have enough information to start developing your differential diagnosis. This should include ACS, asthma, pulmonary embolism, pneumonia, bronchitis, pancreatitis, pericarditis, myocarditis, and costochondritis. How do we start to risk stratify if this is actually a pulmonary embolism? Well, we can look at the PERC rule and the Wells criteria. The PERC rule helps us to rule out a pulmonary embolism if all the criteria are negative. To do this, we look at age, greater than 50, heart rate, greater than 100, O2 sats below 95, a history of pulmonary embolism or DVT, recent surgery or trauma, hemoptysis, exogenous estrogen, and unilateral leg swelling. The Wells criteria is a prediction rule to help us determine how likely the patient is to have a pulmonary embolism. We look at things like clinical symptoms of a DVT, other diagnosis less likely than a pulmonary embolism, heart rate, past immobilization or history within 4 weeks, a previous DVT or pulmonary embolism, hemoptysis, and malignancy. When we add up all the points, we can then place the patient into a risk category. High risk for pulmonary embolism is greater than 6 points, moderate risk is 2 to 6 points, and low risk is less than 2 points. So let's look at Jenny. Her vital signs show a temperature of 37.8, heart rate of 110, blood pressure 116/78, respiratory rate 26, and oxygen saturation at 97. Pertinent physical exam findings include tachycardia but normal heart sounds, tachypnea but breath sounds clear bilaterally. Her abdominal exam was benign, and extremity exam showed that her right lower extremity had +1 pitting edema. Our immediate interventions should include starting an IV, placing Jenny on oxygen, probably just 2 liters by nasal cannula, and putting her on the monitor. In taking a look at our rules, the PERC rule doesn't really help us with Jenny. While she is under the age of 50, her oxygen saturation is greater than 95, and she has no history of DVT, PE, or recent trauma or surgery, she does have a heart rate over 100, is taking birth control pills, which counts as exogenous estrogen, and she has right lower extremity swelling. So we should look at the Wells criteria to determine how at risk for PE Jenny is. Jenny has clinical symptoms of DVT, so she gets 3 points for this. Right now, we're also pretty convinced she might have a pulmonary embolism, so she gets 3 points for this as well. Her heart rate is greater than 100, so that's another 1.5 points, not the 3 points you're seeing on your chalkboard. Her long flight from Australia counts as immobilization, so that's another 1.5 points. No history of previous DVT, PE, no hemoptysis, or malignancy, so no points there. Overall, when we add up all the points, Jenny fits into the high-risk category with 9 points total. What diagnostic tests we order will depend on the patient's risk, but in general, we'll get at least a CBC, CMP, chest x-ray, and EKG on these patients. In general, getting a D-dimer versus a CTA will vary depending on which attending you're working with. Most will be okay with getting D-dimers on low and moderate risk patients, and many will go straight to the CTA for the high risk patients. D-dimers can be tricky, Sometimes you'll roll the dice and get a D-dimer on a patient that you're sure doesn't have a PE, but then when it comes back high, greater than 500, you've pretty much boxed yourself into getting imaging, generally a CTA. However, if it comes back less than 500, you can usually feel pretty good that the patient's shortness of breath isn't a pulmonary embolism. Jenny is high risk, so she'll most likely be getting labs and a CTA. Now, what do you do if your patient's creatinine is elevated and you can't give them contrast, but you're pretty sure it's a pulmonary embolism? Well, you can always get lower extremity DVT ultrasounds, or if you're planning on admitting, you can get a VQ scan. Okay, we went searching for a pulmonary embolism and found that Jenny had one. Now what? ED management treatment is pretty standard for the stable patient. You'll want to start anticoagulation, usually heparin or Lovenox, then someone else will bridge the patient to Coumadin. For your massive PE, any PE that causes hypotension, right heart strain, or arrest, you may want to give TPA or call IR for an embolectomy, depending on the situation. If this is a repeat PE or the patient has contraindications to anticoagulation, you would want to consider admission for an IVC filter. For your disposition plan, if the patient has no insurance, no follow-up, comorbidities, or inability to give self-Lovenox injections, they will probably need to be admitted. Occasionally, if the patient is insured or can afford Lovenox, or if the patient has good follow-up, we might be able to discharge them. Your discharge instructions should include Lovenox training, a Coumadin prescription, and follow-up with their primary MD for INR monitoring. This concludes our podcast. Thank you for listening.